pleasure to welcome you and listen to your talk on this platform. Uh, for people who are just joining us and who've joined us, let me introduce Dr. Nandi to you. So, Dr. Sulakshana Nandi is the co-chair of the People's Health Movement Global Steering Council and National Joint Convener of Jan Swasthya Abhiyan. PHM is a global network of grassroots health activists, civil society organizations, and academic institutions are advocating for the right to health and has a presence in over 70 countries, particularly low and middle income countries. Dr. Nandi has worked for over uh, 2 decades as a public health researcher and activist. Her work in the field of public health spans research, capacity strengthening, and advocacy related to health equity, health systems, health financing, human resources for health, financing, public policies, and programs for health and nutrition, and the social and commercial determinants of health. Dr. Nandi has worked in multiple states of India, supporting community-based organizations, particularly of women and indigenous communities. She currently works in the state of Chhattisgarh and is actively involved with the Public Health Resource Network and the Right to Food campaign in India. Dr. Nandi holds a PhD in public health from University of Western Cape, South Africa. We welcome you, Dr. Nandi, and looking forward to an informative talk. Over to you.
Thanks so much, Asmita, and thanks to the group for inviting me for this talk, because I think I think this particular theme, I think for this topic, whether universal health coverage, especially, it's very important for young economists and social scientists to really engage with it, because in a sense the problems have actually arisen from having a very economics kind of a perspective and not really looking at health or public health, and I think you all also will be the best people to sort of also counter some of these processes that do not really promote people's health. So I'll share my screen and let's hope the slideshow works. Yeah, is it working? Yeah, great. So I'll be speaking on some of the evidence and some of the things to keep in mind with regards to universal health coverage and specifically publicly funded health insurance schemes that are being implemented in the name of universal health coverage. And in many of the LMICs or countries of the global south, UHC has been sort of construed as insurance coverage or coverage by an insurance scheme. So just to start with the, has my slide moved? Yeah, okay, great. To just start with the acknowledgements that what I'll be presenting today is really a collective work by colleagues and comrades from the People's Health Movement, both globally and in India and in Chhattisgarh, and the research and advocacy by the Public Health Resource Network. And also some of it would be part of my PhD, in which I've exactly looked at this topic. And of course, the health activists and the community health workers of Chhattisgarh, who has been really, struggling for ensuring people's right to health and resisting various efforts to privatize and commercialize healthcare. So just to give you, oh, I'm sorry, the photo is slightly blurred. So this is what the WHO basically calls, universal health coverage. So it is supposed to be coverage in terms of population, coverage in terms of services, and coverage in terms of financial cost. And this is the, the cube, the UHC cube, as it has been seen. But this cube is really not without its critiques, and one of the critiques by colleagues in the People's Health Movement has been that, the term coverage rather than universal healthcare really, again, limits the scope and, undermines the comprehensiveness and, integrated healthcare, that is required. And it has, like I said, it has been basically conflated with insurance coverage, and also involving the for-profit private sector in providing healthcare under these insurance schemes. So while I'll be talking about some of the evidence on this, the other issue that has been highlighted has been that, the way the mainstream UHC discourse goes, it risks undermining primary healthcare, and specifically comprehensive primary healthcare, as espoused in the Alma-Ata Declaration. So we'll just look at how some of these things are, what's the evidence on some of these issues in LMICs. So I'll just start with some of the key things that we really need to remember, and some of the, these, of course, these concepts have been there since beginning, but this has, since quite some time, but this has really been used by the within the UHC discourse, and it continues to be used, and basically shaping and designing any schemes or any interventions under the universal health coverage. So the first one is new universalism, and which is a belief that, in healthcare provisioning, the ownership of the facility or the provider does not matter, and instead what matters is efficiency, quality, and competition. So this is one of the things, and you will see how this sort of is reflected in the design of these schemes under UHC. The second is following from new universalism is basically the role, what is the role of the state and what is the role of the private health sector. So it espouses a provider-purchaser split, which is supposed to make, all these aspects, dimensions of efficiency, quality, competition much more sort of effective. So the idea is that the private sector would mainly provide the services, while the the state's main role is in regulation, is in stewardship, and is in financing and funding. The third, then following from that, is the concept of strategic purchasing, which is that the state's responsibility then, if it is funding health services from the private sector, it's his responsibility to engage in purchasing contracts with the private providers. And as you know, you are all economic students, and markets in healthcare have always sort of, there've been huge failures, and this so from purchasing, this word strategic purchasing has been used in order to emphasize that, this is a way that, the government can perfectly buy services from private providers, and through strategic purchasing, and not merely through purchasing, you can mitigate market failures, and it can also be used as a way to regulate the for-profit private sector, as when especially in LMICs, where it is quite unregulated and exploitative. And the fourth aspect to be kept in mind is that in the UHC discourse, there is a huge amount of emphasis on public financing. So that's something that there is a consensus on. And, you speak to anybody, from even from the World Bank to the World Health Organization to anybody involved in this, they will agree on this point that it should be public financing and people should not have to pay out of pocket fees for the services. But in the global health community and within the mainstream UHC discourse, there is a very little emphasis on public provisioning, mainly because it basically espouses new universalism and provider purchaser split and purchasing from the private sector, and not really strengthening or the public sector to provide these services instead. So what are these? So some of the key characteristics of such schemes which have been pushed under UHC in many of the LMICs. I mean, I think the first thing to say is that it is the schemes are very different from the kind of socialist social insurance schemes that many countries have in Europe, for instance, and where because in many of them you have public providers, or even if you don't have public providers, many of these countries do not allow for profit as much, profiteering, and so that's one thing to understand, that how that these are very different from the kind of rationale that social health insurance developed in, for instance, post-war Europe. So the rationale for this new wave of insurance schemes in LMICs, I mean, one, of course, is to reduce the financial burden, but that is through efficiency, quality, competition between providers, and to be able to provide a choice for people. So very much, when you look at it, it's very much embedded also in the neoliberal ideology. So, all the rationale for, that is present here. So the other key characteristics we see throughout the, I mean, in most of the countries, especially where there are mixed health systems, and you have some kind of a public sector, and then you have for-profit private sector, that there is such schemes also have an explicit objective of favoring and engaging the for-profit private sector, promoting commercial interests and promoting the commercial, the healthcare industry. So that's something that is quite explicit in some of these schemes. And the other things are an over-reliance on digitalization and information technology systems, on your biometric ID cards, and the national health insurance cards. So all those are again a common characteristic. But the other thing is that most of these models are not very transparent, and I'll just go through why that's so. And they also lack some level of public accountability that is there with ministries of health or the government services. So one reason for this, and what we see as a model, is that strategic purchasing agencies are being set up, which operate outside of the Ministry of Health, and they are usually agencies which are set up with a multiple profile board. So you will have somebody from the corporate sector who's on the board, and somebody from maybe the health ministry, somebody from the pharma sector, somebody from industry. So so examples of that is the National Health Authority in India, and also the Philippines Health Insurance Corporation. And not only this, I mean, even in Kenya, they set up a fund, and in India especially, you can see that in many of the states, I mean, this is the national authority, but in many of the states, such agencies, such authorities have been set up to manage and purchase from the private sector. So the other common factor is that there is also a lot of support by global actors, by philanthrocapitalists, a lot of funding by Gates Foundation on these aspects. Global health academia, global institutions, especially WHO, I mean the World Bank, ADB, and some sections of the WHO that sort of pushes some of these reforms. And like I said, it's more from the financing side that this happens. So a lot of their support, proactive support, goes into developing capacities of ministries of health, or for government, or for these authorities, on developing capacities for strategic purchasing. So providing technical support to them, providing funding resource agencies that can develop packages for purchasing and for insurance schemes. So all that technical work. But I think so. But the key characteristics, as we will see as we go along, the main failure has been seen in countries that mainly purchase such care from the for-profit private sector, and for various reasons, and the implications for people on their financial protection, for equity, is quite disastrous. And I'll just go through some of the examples. So Asmita, if you can just ping me when maybe I'm 30 minutes over or something, and then I can conclude. Yeah.
Sure. I will let you know the
so
time.
sure. So the first one is Indonesia, and I've tried to give a list of the references, but there are many more at the end, and I can also send them, share them separately with you all. So the Indonesia National Health Insurance, again, it covers outpatient, inpatient care. And while the coverage is high and studies have shown that utilization has increased, there's really not they've really not seen a significant impact of out-of-pocket expenditure or catastrophic health expenditure. And along with that, inequitable access to health services continue, because the kind of distribution of healthcare facilities and private sector, so in a lot of the, for instance, the remote islands, in Indonesia, there won't be any private sector, and so people are not able to access, and the public sector, like we will see, is underfunded, and through and such schemes have also led to further imbalances between the public and the private sector, very similar to what we see in India. In Indonesia too, around 3/4 of the insurance fund is going to the private sector. That really means that there is less and less money in the public sector to strengthen the public sector, pay for salaries, pay for all the other systemic inputs that are required. The second example is the Philippines, and the insurance scheme has been going on for quite some time now. And it again mainly promotes the healthcare and the private insurance sectors. And while enrollment has increased, there is a lack of financial protection, and that too has been documented. In Morocco, again, the private sector, especially in the private sector, there's been cost escalation, has been seen, overbilling, patients having to make additional payments. And as with Indonesia, and I'm sure with many other countries, led to imbalances in financial flows, where the 90% of the claims are going to the private sector. And then if you've already had a underfunded, neglected, weak public sector, it becomes weaker and more underfunded. And the other thing that Morocco has documented is the shifting of workers, health workers, from the public sector to the private sector, something which I fear we will start seeing after some time in some of the other countries like India, where this has not yet as such happened, due to the insurance scheme. But I'll talk about India separately. So, I just want to point out here, when this kind of a scheme, which is only which only has a financing dimension in mind, and it really doesn't see how the health system is going to work, what is going to happen to the health workers, what is going to happen to the different levels of the health system, to primary healthcare, secondary healthcare, tertiary, how are they going to sort of integrate with each other? And and that's basically such integrated facility is only possible through a integrated public system, and it's very, very difficult to visualize the private sector contributing in that way to integrated comprehensive care. So that's one of the failures, in terms of yeah. So I mean, a lot of loss on in terms of a lot of the building blocks for the public sector due to this these kind of schemes. So Kenya, like I said, this also set up a fund to act as a purchaser, and they've also set up a regional technical agency to provide capacity building for purchasing, called the Spark, which is well funded by Gates and many other organizations. And but studies have shown that there is a pro-rich pattern of utilization, inequity in enrollment, financial protection, and of course in geographical inequity in distribution of hospitals that we see in most especially private hospitals that we see in most countries in our region, and along with that very little consumer engagement, feedback or redress grievance redressal systems very weak. So I'll just spend a few minutes on the Ayushman Bharat PMJY in India. So so it is so the national health scheme started in 2009, the RSBY, and it was expanded in 2018, and there was an increase in insurance coverage, and the scheme has focused on inpatient care, hospitalization, and as we will see that it is and there is always a push from many quarters to include outpatient care, but that as we will find, it can be more dangerous because and more uncontrollable, to regulate outpatient care. In insurance, in hospitalization, you can at least count your beds which are there in the hospital, but in outpatient care, it's really impossible to regulate in that sense. So let's see what's been happening in terms of the hospitalization. So we find that private hospitals are unequally distributed and concentrated in cities, and there is higher utilization in the private hospitals because they are the ones to sort of who keep trying to attract patients, and even though the utilization is on a very small set of services, and there is cherry picking by private hospitals, but there is also a lot of unnecessary and irrational care that is provided. And for instance, in India, in many states, there's been hysterectomies and high cesarean section documented under these schemes. So the other thing that happens with access and utilization is that areas which the poorest districts and populations, which include areas where more scheduled tribes live, or scheduled caste members live. So there there's sort of a they are enrolled, but they're unable to utilize the service and utilize the access. So the money that is allocated for them basically gets spent in the better off districts and in the non-tribal districts, and that's been seen across the country in various in various states. So the second, so the most important thing has been, issue dimension is financial protection for UHC and for the health insurance scheme. But even on that dimension, studies have shown even previously when, whether it's RSBY, whether it's the state schemes, every state has a certain sort of adapted schemes to PMJY, but it has not led to cashless services, and people continue to incur out-of-pocket expenditure and often catastrophic health expenditure because there is extra billing by the for-profit private hospitals, and the systems for regulation are not do not work. And secondly, even culturally, I mean, even there is a power imbalance between the medical profession and people who are going to access care, and it's very difficult to negotiate and navigate that system, and that relationship and that negotiation is really fraught with a lot of problems, and the patient or the poor person who is there really ends up paying. And so that's on financial protection also, it really has not worked. And the other thing, another dangerous thing has been the impact on the public health system. And even under PMJY, if you look at the data, more than 75% of the claim amount has gone to the private sector. And like I said, it also means that, in areas where the public system is weak, and people are not able to access secondary or tertiary health services, the money allocated for them is being spent in the more urban areas, and in the more private sector in such cities. And there is inequitable distribution of claims that is happening. And alongside that, the funding and prioritization of PMJY has resulted in simultaneous reductions, stagnation, and of allocations to other public health programs, maternal child health programs, disease control programs. The whole of National Health Mission budget has really remained stagnant, whereas the second the second part of the Ayushman Bharat reforms, the health and wellness centers, that has really has an opportunity to make a huge difference in equitable and free primary health care for people, has been really badly under funded. So that's another problem that has happened. And the other issue that I want to highlight in India is the impact on governance. So there has been from the beginning explicit involvement of the corporate sector and the private sector and organizations who sort of act as their agents, from design to implementation to evidence building. And it really also legitimized role, for, like I said, institutions like the National Health Authority or the trusts that have been set up in various states, legitimize the role for the for-profit private sector, the corporate sector in government policy making. And, so then your decisions that are made, who are they going to be for, in whose interests are these boards, going to serve? And especially in India, it's very blatantly the PMJY is promoted as a business and as something that people can, hospitals can do business with. So what happened during COVID-19? I think all of us who were in India, have family in India, really experienced this. And initially, the private hospitals really closed their services, and when they resumed, they engaged in a lot of price gouging and inappropriate care and denial of healthcare, especially of COVID patients. And while states did attempt to regulate the private sector, most failed, and at least some the states where the public sector was strong, they were able to regulate the private sector to an extent. So the PMJY really failed to a great extent to provide free healthcare for COVID-19 or for other diseases during that period. So a study done by the National Health Authority itself says that in the first week of the lockdown, even conditions such as pneumonia, respiratory failure, fever, etc., that could have been associated with COVID-19 symptoms. There was a decline in hospitalization. And other studies have also shown the kind of abuse and extortion that that has that the for-profit hospitals did, and these are some of the papers. I mean, a lot of them are media reports. There's an excellent collection of case studies that has recently been published by Sati. Please try to access it. I can share the link also. And so, which had stories of patients' voices of how they tried to struggle, they fought, when they took a patient to the private sector, but they still had to, they were forced to pay the money. So finally, what do we conclude from this kind of from the experience that we have in some of the countries that have mentioned? So we find that utilization increased in some schemes, but it was inequitable, and there's inequitable access based on geography, geographical regions, rural, urban, social groups, where the more vulnerable communities are getting left out. There is a pattern of unnecessary surgeries, tests, drugs under health insurance. Selective services are being provided and by the for-profit providers, and who engage in cherry picking. And because you have to, for such a scheme, you have to sort of develop packages and things like that, and it really cannot be comprehensive. A large number of diseases or conditions get left out, when you sort of have packages like that. So basically, what the experience from our LMICs, we find that private provisioning really destroys all advantage of public funding, because it finally does not ensure equity in access utilization. Similarly, in financial protection, there is evidence from across the world that they have not led to financial protection, and it's only been and this is especially in countries where the for-profit private sector has been contracted. There is mixed evidence from Ghana, because there it is mostly non-profit hospitals, and like we've seen, most private facilities charge extra, which they're not allowed to charge, and therefore people have to keep paying money. So it is a so when we look at the countries in South Asia where we have these schemes, there is coverage, but there is no financial protection. Again, I mean, I'm not going to repeat the impact on public and private sectors. I mean, I think it's similar. We found for many of these countries that the funds got reduced from the public sector for the public sector, and the private providers basically are the biggest beneficiaries. And even countries where there is dual practice, there's a lot of collusion and conflict of interest that is created when you yourself have a private hospital and you're a government doctor, so you would rather refer the patient to your own hospital and get the insurance money rather than treat them at the district hospital. So in many countries, provider and regulatory capture by the private sector has been seen. So insurance as a mode of financing and incentivizing does not seem to have worked in the public sector, and has really exacerbated the problems faced by people who are going to the for-profit private sector. And I just want to highlight some of the oft-quoted successes of strategic purchasing. So when you look at the literature on strategic purchasing, Thailand comes up as a very as a huge success story of UHC and of strategic purchasing. But often people fail to mention that it's a predominantly a public sector based healthcare system in Thailand. So nearly 90% of hospitalization care and 86% of outpatient care are in the public sector. So they have a financing arrangement, but it is from the public sector itself and not really from the private sector. Again, Costa Rica model is also similar to Thailand. And I will share the link to a video that recently the People's Health Movement developed on health systems, equitable health systems. And it is very interesting that Costa Rica basically abolished its military because it had a commitment to spend on social sector, so to spend on health, education. So it has a very different sort of a very different sort of a perspective in terms of health, as a public good, as a thing of solidarity that needs to be provided to all people of the country. So Ghana, like I said, again is talked about as a positive purchasing example, but it's mainly based on faith-based non-profit organizations. So I just want to, I think a few slides, I just want to highlight how some of these processes are being, further sort of negotiated at the global level and global institutions. I did start from UHC and how that came in terms of and what was the role of the various global institutions and the influencers and the sort of the global power elites in designing some of these things. And then we went on to how what that means for different countries and for people in those countries. So this is to get back to the global level and just to say that more and more global health institutions are being sort of captured by private interests. And this is a recent report that really maps a number of these multi-stakeholder institutions, which, like I said, when we talk about the National Health Authority in India, this is like similar governance structures at the global level that bring in the corporate sector, for-profit, private sector, pharmaceutical sector into global health decision-making bodies. And we've seen during the COVID pandemic what disaster that has been for equitable access to vaccines and other COVID essential products. So and just also another sort of caution that we talked about, most of these schemes are based on hospitalizations, but there is a very strong push in recent years, in current times, to introduce and expand strategic purchasing in primary healthcare services, including in India. So some new developments that we need to be vigilant about and keep monitoring. So there's the operational framework for PHC by WHO and UNICEF. There is a Walking the Talk Reimagining Primary Healthcare After COVID-19 paper. And then there's the Lancet Global Health Commission on Financing Primary Healthcare. And all three basically are talking about financing arrangement, payment arrangements, purchasing arrangements, and so on. So so this is something we really need to be vigilant about. And I know there is a lot of frustration and about the public sector. So I just wanted to end with some positive examples of can public sector be strengthened. And I think in India, we have enough examples from Kerala, Tamil Nadu, Rajasthan, in some either on improving the public sector hospitals or on specific dimensions, like medicines, human resources and things like that. And the other example I would like to give is of strengthening the tertiary and secondary hospital in conflict affected districts in Chhattisgarh. And the third one, I would urge you to read on the Health and Wellness Center, the HWCs which is the second part of the Ayushman Bharat reforms, which really, in a sense, converts the subcenter into a well-functioning, functioning outpatient primary healthcare center with an additional human resource. Like, this is one of the few times that additional cadre of community health officers has been introduced in the health system, and if done well, and we've had many examples of from Chhattisgarh, from Assam, from Tamil Nadu, where it's really made a huge difference. So just to talk about very briefly about the way district hospitals and community health centers in Dantewada and Bijapur in Chhattisgarh have been improved. And there was a study that we did with WHO, and really it was the district administration and the health system, the health department there, that tried to use various ways of financing, various arrangements, but finally to strengthen the hospital, the public sector hospital that is there. And many of you who are familiar with India and Chhattisgarh would know that these are some of the most conflict affected areas of the country, some of the most conflict affected areas of the country. So they made an effort to recruit human resource, and it clearly showed the difference in the health services delivery and utilization. So I think so the question is, if it can happen in the the remotest and the the most conflict affected districts of the country, why can't it happen elsewhere in the country or in the world? So the second story I want to share with you is about this documentation that is ongoing on stories of remunicipalization and deprivatization. The website is there. And in fact, from Chhattisgarh, we've just completed a case study, which is, we're going to publish it, but this is a synopsis of that case study, in which the advanced cardiac heart unit in Raipur in Chhattisgarh, which was initially set up as a public-private partnership with Escorts Heart when Chhattisgarh was formed in 2000, or it was set up in 2001, basically got handed over to the government. The government took it over, and it's made a huge difference in the kind of access to this kind of cardiac care. Otherwise, there is a notion that high-level tertiary care is best available in the private sector, but this case study really counters that, and the kind of people who are who are able to access the services, access cardiac surgeries and healthcare has really changed. I mean, there was in one of the interviews, the respondent said, earlier people, when it was under Escorts, I mean, it was still government money, and government resources when it was under Escorts. But at that time, people would come in your big cars, now that it is government, and the way and the services are free, so now even people come by public bus or by cycle or by their own scooter. So there's a really marked change. So this is not the only case. Like I said, you're welcome to go to the website and check out. So it's across themes, not only healthcare. You have energy, you have power, you have roads, you have water. So a lot of those cases, and I mean, there is not enough documentation from South Asia, so it would be great if if any of you know of such cases, even at the local level. I mean, it can be at any level of government. You can share that. And I also just want to say that, while the COVID pandemic was on, and while, the government, the health insurance schemes really failed us, and the kind of dominant power, sort of the hegemony that is there at the global level, social movements and campaigns have continued to resist such things, and really try to again and again put people's voices, and voices that put people over profit in these struggles. So just some maybe recommendations for what we can all do together on this issue. So I think the first thing would be to remain vigilant and document and scrutinize the evidence that is available, because a lot of the published papers are also by people who promote the schemes or have money to promote these ideas, and so automatically, and publishing again is a very political and issue, and whose paper gets published, whose evidence is seen as evidence. But do continue documenting and scrutinizing the evidence that is put before you. Then document, examine and critique the dominant narratives that put profits before people, and do intervene whenever these conversations get captured by private sector, including in global institutions. Demand higher public investment, strengthening of the public sector to provide really comprehensive and integrated healthcare from the primary level to the tertiary level, along with, of course, the regulation of the for-profit providers. And the other thing would be, it's important to demand expansion of public employment, like I said, and I think this is something that Professor Jayati Ghosh has also been saying a lot, and so we've taken lessons from her and her suggestions. So, finally, it is about the system that you want, the society that we want. And, if it's just to sort of pay for one package, one operation, that really doesn't work unless, you are developing a system. It's also a way of, redistributing wealth. It's also, for instance, for communities that have experienced, historically, marginalization, exploitation, and abuse. It's also an issue of, reparations and, developing systems that are going to respond to them, to cater to them, rather than keep making profit and money for people who are already, rich and privileged. So as scholars, academics, health activists, we must come together and build solidarities, and it's really important that we shift the normative environment in healthcare from, the market-based commercialized healthcare to a system which is based on solidarity, human rights, social justice, public accountability. So these are some of the references, and I welcome you to join the struggle for health. Yeah, thank you.
Thank you so much, Dr. Nandi, for that informative talk and very, very interesting session. And I personally learned a lot of new things in the field of, strategic purchasing and all of that you said. I now open the floor to questions and comments. So if anybody has any questions, I would suggest you to please raise your hand and I will call out your name.
I can probably start with, thanks a lot for your really, enlightening session, because, we as economic students normally have some technical sessions on the health, but health insurance and health economics. But, it's really wonderful to hear somebody from on the field experience and, from a much more active perspective. And I completely stand with your call for solidarity across everybody interested in health, and hopefully we can continue this association with young scholars also to build that solidarity. But when the Ayushman Bharat scheme was about to be implemented, we had one of the sessions that we had at YSI was on how this this insurance-based schemes have always been a failure especially in countries where regulatory mechanisms are really weak. Okay, and your perspective really adds to that. It's not just regulatory mechanism; it's like a political pressure and a socio-political angle also into that. And probably these are all interconnected. But would you order? What would be your comment on regulatory mechanism versus, because we all agree and we stand with you to say that insurance, publicly funded insurance is the right way to go. It is, the privatization efforts are happening across the world, but the thing is, it's not really the failure of regulatory mechanism, isn't it so? Or it is the political what do you say, a propaganda that is driving this rather than failure of regulatory. Because right now the country that I am staying now is having a good. I am right now in USA. It is spending the highest amount in the world for health, and it's all going to the law firms. All the health amount is going. So if we increase GDP spending on health, it's just going to some other sections. That's what I. So maybe I would love to have your comment on regulation versus, because that is what many economists argue. Regulatory mechanism should be stronger. We need institutions which are really strong in regulation, etc., etc. So over to you, ma'am.
Yeah, thanks, Arun. I think you've really hit the nail on its head. It's not a regulation is. I always say it's not a technical issue. There are techniques that there are ways you can do it, but it's not that people don't know how to do it. So it's a completely political, and a cultural thing too. And, depending on who is in power, whose voices are heard more, whatever systems you set. So unless you will see, if your society, if you have a more democratic system of governance, and there is space for people to express criticism or grievances, and so automatically, many of these things, in such societies, you will find that, there is, a culture of kind of regulation from the bottom. But so it's not a technical thing, it's a matter of power, it is a matter of politics. And let me just also tell you that, I think even the experience from the global north, you talked about USA, but during COVID in the UK, and many of you may be already in the UK, there was a lot of outsourcing of testing and tracing, and it came under such a huge criticism, because and even previously, some of the way the NHS hospitals are slowly, being privatized, but just to be on the immediate example, that so much of money was given to these companies, and the government really did not have anything to show for it, in terms of the outcomes or the outputs of those companies. So it's not only in the global south or in LMICs. You see, such failure. Whenever there is market, there is profit involved, there is a profit motive involved, it will be, nearly impossible to regulate. And you've really not had any examples, of regulation where, there's profit motive involved, especially, and in such issues that, which are, issues of life and death, of social welfare, some of these sort of things that need to be considered as public good, and whether it's education, whether it's health, whether it's subsidized food income. So these things, you cannot, I think it's impossible to regulate them if you have the profit motive and the commercial motive in it. And I just want to also highlight there's a paper on strategic purchasing that brings together experiences from Europe on, again, failures, how even Scandinavian countries, when they tried it, they were not able to do that. So I think the core is that, profiteering, profit making, and you have to, you cannot have a profit-based system providing, you cannot achieve universal health care or social justice, for that matter, through a profit-based system at all. So one has to, look at it, I think, in that way. Yeah.
Really looking forward to receiving all the materials that you were mentioning during the talk.
Okay, I think Satvik, you had a question.
Actually, nobody was asking question. I thought I would be asking the warm-up question, but I can do the same again. But let's see if someone else is going to ask. Yeah.
Can I ask a question?
Yes, please, Urvashi, go ahead.
Good evening, Dr. Nandi. Thanks for your informative talk. Just wanted to ask you, since you've been on field and you've sort of studied the scheme in detail, have you seen a switch in the utilization pattern of the patients, as in once they were aware of the scheme and once they got their cards? Did you see a shift in their utilization? Did some of them move to private healthcare? And for what kind of procedures were they moving? Or, as you mentioned, that in the better off districts, there was the resources were being diverted to the better off districts vis-a-vis the tribal areas and the worse off ones. So did you see any change on the field with regard to utilization patterns?
Yeah. So, I think it's a very interesting question. And when you look at, so we have studies on the NSSO data looking at this point, in terms of utilization. And you actually find that despite all this, neglect of the public sector. Even in the scheme, the women, tribal families, and families of socioeconomic, the poorer families, they are still utilizing the public sector more, because that is what is available to them where they are, because there is no private sector there. And we find when they so there have been a lot of instances when there was a case here in Chhattisgarh, in which this so Pahari Korwa is a particular Pahari Korwa community is a particularly vulnerable tribal group. So they thought that they would be able to get the service. I mean, they had gone to the district hospital, and from the district hospital they sent the patient to Raipur, to the capital, the state capital, to a private, to the government medical college. But the ambulance driver brought them to a private hospital. And even though, and they said, this card is there and you can utilize it, free of cost. You can. And that family, that patient was stuck there for 3 months, because they kept asking them for money for, 4 lakh, 5 lakh rupees, and which was impossible for them to pay. And he and his daughter-in-law was there to take care of him. And, she used to not eat, because she should just eat once a day, because they would get food for him thrice a day, but she would just eat once a day, because, and then she smuggled herself out and sort of informed her family members and, about it. So people who are even accessing the private sector, and of course, like you said, there would be services that may not be available in their district, or like I said, in terms of referrals, sometimes, I mean, this kind of collusion between the public sector and the private sector health providers, but the experience, but the experience has been quite traumatic, especially for the poorer communities who have attempted to access healthcare in the private sector. And and of course, but you do see in the urban areas, like I said, that's why the utilization is shows much higher in the urban areas. So in the urban areas, people do then go to the private sector, and especially because in many states, the public health system is not very strong in the urban centers. I mean, through NHM, it was initiated as NRHM, the National Rural Health Mission. There was quite an expansion of health facilities in the rural areas, that we really see that expansion and that increase in utilization of the public sector in the rural areas, but that isn't there in the urban areas. So that's one thing. And so that attempt is there in the urban areas. And I'll share a paper that I wrote as part of my PhD, in which it's a qualitative paper where I interviewed 8 women, and of what they went through when they went from urban slum here in Raipur, of what they went through when they went to the private sector, in the so this kind of experience, when they go to the private sector, they do experience that. But on the other hand, they've also, in states where there have been good tertiary level public hospitals, or the district hospitals have been good. So overall.
The reason I'm asking is because there is this clause in the scheme PMJY where they say that, there's no restriction, as in anyone from anywhere can access a hospital.
Yeah.
So, do you think for really higher level tertiary services, maybe there is the utilization?
So the problem is that people don't finally get free services, so they may go there. So it's actually in that study, one of the respondents said it's like he jaise sher ke tumko card, they show you the card, and they put you in the lion's den, like a goat. So they send you to the lion's den, and then they leave you. So the card is attractive, that okay, we are covered by insurance, and in that hope, some people are going to the private sector. But she said that it is like, the government is throwing you into the lion's den, because once you reach that private hospital, you're just unable. I mean, however much you shout, scream, and struggle and try to negotiate, the power imbalances and the structures around you are do not respond to your problems. So you poor people, or people who are in fact who are I mean, not very powerful. I mean, you may have examples of, like, the ministers, some relative getting completely free healthcare, because they know that if they take money from that person, they might complain and all. So it really depends on how your voice and how much voice or power you have. That depends on the way how you are experiencing this utilization of the scheme.
Okay. Yes, Suresh, you can go ahead and ask your question.
Yes, ma'am. It was like nice presentation. So I want to ask two points. One is with respect to when we are talking about financial protection, like most of them are not aware. Like, as someone is saying that there are 60%, like there is a inequality between rural and urban. So most of them are not unaware about these whatever schemes we are talking about. Another scheme, like we will see that Jan Dhan Yojana you were mentioning in some slides. So where if you take an account in that, you will get a RuPay card. Like there is a insurance attached to it. So do you have any data on that? Like how many really got the insurance benefit of that RuPay cards? Because like those who opened account under the scheme are actually, now we see that it may be because like maybe multiple accounts opened, and another thing is now there are so many dormant accounts. That is one, ma'am. Another thing is with respect to the role of Ashas and Angadwadis. So they are actually the building or very much backbone for this health system in India. But their services, like when it comes to some immunization programs, or we have seen in COVID situation like tracing, testing, all those stuff, we have seen the role of them. But still, the government is not recognizing them as a government employees or so on. But like in supply side, we see that there is a lot of issues. And recently, we have seen that like many of the medical students are stranded in Ukraine. So that means whatever the medical infrastructure in India, we have locking on that. So what are your thoughts on this?
Yeah, thanks, Suresh. I don't have any information on the Jan Dhan Yojana, but I'll just talk about the this health insurance, this RSBY and the PMJY kind of health insurance and the kind of awareness there is. See, I mean, it's been nearly, I mean, 15 years. Since RSBY has been launched, and so I mean, I know that there are there is some kind of, I mean, there are papers on awareness and how people are not aware that their card, they utilize it. But it's not only an issue of knowledge; it's also an issue of experience. So what you call awareness or information. So it's an amalgamation of how they have experienced, or how their colleagues, I mean, how their people in their community have experienced this information, this insurance scheme. So in fact, I'll paste the link to my paper, and in case you're unable to access it, we can I can send it to you. But I mean, so what I found was that it wasn't lack of information. The families had complete information on what they were supposed to get, but they also knew very well that they are not going to get cashless services. They knew that the private hospital is going to say ki, I will cut 10,000 from your card, but you will have to pay me 10,000. So they were very much aware of so in that sense, I mean there might be some issues of awareness of the knowledge of how much money is one is eligible for and what the packages are for. But but in terms of utilization, actually going and utilizing it, we have found more problems from the provider side of denying them healthcare, saying, oh, my hospital is not empaneled under Ayushman Bharat. Now, how does the person now know how the hospital is empaneled? So, so all these, that your biometric card and, I mean, initially in Ayushman Bharat, they said that there won't be any biometric card, but then last 2 years, they've been busy making these cards and maybe making them into that health ID that the government is talking about, but without any explicit consent of a health ID, being made. So that's another issue. When this kind of digitalization of information then leaves the patient with no access to their information. Now the NHA will say, no, there is a booth there at every district hospital, or there is a person at every private hospital, but it's not easy for people to go and check how much money they have left, and every time, and get a receipt for what they have, what has been spent from their card. So I think the systems are really not meant for people, to be able to use it. It's really meant for the providers, the way the systems are developed, to take advantage of. So I'll share the paper. I've dealt with some of these issues of information and awareness, and how it's, like I said, it's like an amalgamation of your experiences, of how you have experienced the scheme and how the society or the community experiences such interactions, and that really drives your decision making on where you want to go, or where you can go, and where you finally go. Yeah, thanks. Sorry, sorry, his I think this question on the ASHAs and Anganwadi workers. Yeah, I mean, I think the government has really yeah, I mean, it really exploits these frontline workers, and the way the ASHAs have worked throughout the pandemic, and because I'm very closely associated with their organizations and unions also, and yeah, and the government is completely non-responsive to their demands. So yeah, I mean, even medical education, like you said, needs to be revamped. But again, the problem started when we privatized it, and so I mean, people in India, we keep getting SMSs, text messages saying that you pay so much money and you can get a seat in this medical college. And so I mean, everything, I mean, the medical education needs to be revamped, but then but the government does not seem to have any intention of strengthening the public provisioning of medical education or for health services. The Niti Aayog has last year, in the middle of the pandemic, taken out a PPP paper, a paper in which they have suggested that district hospitals, public hospitals, where the last place of resort for people in many districts who cannot afford the private sector, and so the district hospitals are going to be handed over to private medical colleges. So and many states that process is going on. So there is clearly a need to resist this kind of, which is going to affect everything: health services, medical education, and at all levels of healthcare, health workers.
Yeah, because I've district health, like district health, that hospitals, they are referring to the private hospitals, and they did not say like maybe this covers under insurance, or this does not comes under insurance coverage, but they just refer to the hospital. And after going there, maybe they won't ask like which document or which like maybe this comes under like that. And but mostly they say that, okay, if you have other card, you forgot ration card to bring the ration card, so go and bring, otherwise we'll go into the cash. So like that. So that's why it's awareness is important.
Very true. Yeah, very true. But what I'm saying, I think we need to sort of unpack the word awareness, because see, finally what has happened, in like the example you gave, it is now the district hospital doctor tells me, that you have to go to that place, so I will go. No, again, it's an issue of power, and it's so you know, I mean, if I maybe had the you know, so I mean, so that's what I'm saying, you know, it's a outcome of the interactions that I've had or I'm having along with the knowledge that I have. That is true. But I'm just saying that it's not as simple as, you know, giving them a brochure and telling them, I mean, that's also needed, you know, giving them that information, but it's also the behavior and the interactions and who is referring them to that hospital. I mean, so all those things, I mean, I'm just saying the word awareness needs to be sort of, it's more complicated just than just simply knowledge or information.
Yeah, maybe we can call like, in case of financial inclusion, we'll say financial literacy. Like here we can say health literacy or medical literacy.
Okay, thank you, Suresh. And before we close the session, in the interest of time, we'll take one last question. And Anushri, may I request you to please ask your question? Anushri, are you there?
Hello, am I audible?
Yeah. Yes,
Yeah.
yes. you are.
Thank you.
Please go ahead.
Thank you, ma'am, for that wonderful presentation. My question is a little extension of PM Ayushman Bharat. So the narrative from Karnataka says that one cannot just step into the empaneled, private hospital to get treatment. One has to go through government sector hospital, provided if they don't have the service, then only they can avail the service in the private empaneled hospital. So this was one of the methods that Karnataka adopted to regulate, the private sector and making wrong treatments or wrong billings and things like that. But however, with this kind of regulation, the uptake is really low because we are talking to a kind of mass population wherein the perceptions regarding the government sector services has not been changed. So in that context, my question is how far a state should step in regulating the private sector in reducing, for giving a better protection or, for the health. The second question would be, the NSSO data says that, NSSO, even the NITI Aayog report talks about reduction in out-of-pocket expenditure between, say, 2014 and the latest rounds. So does this mean that while contrary we have evidences of failures of repeated failures of different financial protection schemes? So where do these they do not converge, right? So what are your views on this? Thank you.
Yeah, thanks, Anushri. I'll take the second question first. So, but I will share a paper which actually shows that which compares NSSO data through the last couple of decades and really shows that the out-of-pocket expenditure in the private health sector hasn't really reduced; it's actually increased, even with insurance. So, I think when looking at data, I think it's very important to do the public and private sector disaggregation, and that's something even the National Health Authority doesn't do. So people who want to show things as a blanket thing don't do that, because once you separate private sector and public sector, the differences are enormous. I mean, in all our studies, even in the previous even in the NSSO. I mean, even the study where I analyzed NSSO data, it was like nearly 8-9 times. I mean, 7 or 8 times more in the private sector, the out-of-pocket expenditure, than in the public sector. So I think my first suggestion would be to actually look at private and public sectors separately. And in most cases, the government doesn't do that and doesn't want to do that. The National Health Authority, though, definitely doesn't want to do that. And even in number of claims and number of cases. So I think that's one important thing. And I'll share those papers that show the increase in the out-of-pocket expenditure. Secondly, I think the first question that you've asked, I mean, see, I think, I mean, see, I mean, many states have tried many ways of regulating and things like that. And in a sense, Karnataka is actually one of the vanguards of, you know, commercialized healthcare sector, and, you know, the issues in health governance that I spoke about. And so I think, you know, I mean, for instance, the trust in Karnataka, you know, it has as a board member, the you know, the owner of the biggest corporate chain, who also you know, benefits the most, has always benefited the most from the scheme. So you actually have an private sector provider who utilizes the scheme, who uses the scheme as a board member. So what I'm saying is that, you know, I mean, one has to really look at regulation more broadly. And I mean, you know, I mean, of course, there can, and the other problem with Karnataka has been that, you know, there's so much emphasis on the private sector. The public hospitals really, you know, have not been built up to that extent. You know, something like me being in Chhattisgarh, I've been working in Chhattisgarh for, you know, nearly now, you know, 18 years. And I've found that, I'm sorry, yeah. So, and I found that the public hospitals have improved to such a great extent. I don't know whether in Karnataka they have improved so much, and you know, they are, and whether people are being, like you said, and there is an issue of mistrust with public hospitals, but that's also because the public hospitals have not been strengthened, and they've in fact been neglected. And Karnataka's policy environment has been always pro private, you know. In fact, in the middle of the pandemic, these guys were saying, I mean, the corporate people in Karnataka were saying that the government should pay for the private sector hospitals to have these COVID wards, and pay for all the COVID beds, and pay for all the oxygen. So there was a letter that Kiran Mazumdar Shaw and I think Devi Shetty wrote to the Karnataka government. So I think, see, if there is no intention in developing and strengthening the public sector, and I mean, of course, that will always be used as an excuse to, you know, to provide more funds to the private sector. So, you know, that's a very, it's done widely, you know, where, you know, you really dismantle the public sector services, you dismantle the public services, and use that as a rationale to, you know, promote the private sector, because they are there in such large numbers. But, you know, finally, when you really look at who is providing, you know, equitable health services, free healthcare, or more of, you know, with less out-of-pocket expenditure, and to the more remote areas, to the most vulnerable and marginalized communities, it is the public sector that is providing that care. So, like I said, you know, it's for the state and it's for the society to take that decision of, you know, how they want what they want their public, you know, their health system to look like. And it's not too late. I mean, I know that it's often very frustrating, that, you know, and there's always this rationale of, oh, the private sector is here. It has so many beds, and it has so many people, and it has so many health workers. But finally, if the private sector is not catering to people who need health services the most, or you know, who have the highest, you know, most illnesses and most sort of deaths, and also mainly because of the way society is and the way society has discriminated against them. So I don't think this is a choice. So whenever you look at social, it in the with the lens of social justice, I think it's only strong public services and strong public systems that can enable that. And I think, I mean, one can just take baby steps to reach that. It's fine. I mean, things will not change in a day, but at least, one can keep resisting the other kind of commercialization and keep doing good work and documenting the good work that is being done in the public sector. Thanks.
Thank you, Anushree, for that question. And I would take this moment to formally thank Dr. Sulakshana Nandi for coming to our platform and giving such an informative talk, which is like very informative for all of us. And I hope that you will continue to associate with Young Scholars Initiative in the future, and also share all the resources that you said would be helpful, because we can then share them across people who have more interest. Thank you. I'll stop the recording now.
Thanks.